Welcome back. This is Shanmugapriya. This video is on the topic Cushing syndrome. So, let's get started. Contents. It has a definition, physiology, etiology, clinical features, diagnostics, screening, and treatment. So, let's look into definition. Cushing syndrome is an endocrine disorder that is caused iatrogenically by the exogenous administration of glucocorticoids or from an endogenous overproduction of cortisol. They can be classified into primary hypercortisolism, that is, autonomous overproduction of cortisol by the adrenal glands, or a secondary hypercortisolism, which is an increased production by pituitary microadenomas or an ectopic foci. So, let's look into a brief physiology of adrenal glands. The adrenal gland is an endocrine gland present above the kidney. They have a cortex and a medulla. Adrenal cortex produces three main hormones. The first one is the glucocorticoids, which produces cortisol, which affects the carbohydrate, lipid, and protein metabolism. Mineralocorticoid, which controls the sodium and potassium imbalance, and androgen, which produces sex hormones. Adrenal medulla produces catecholamines. So now let's see the etiology of Cushing syndrome. As said earlier, Cushing syndrome can be produced, its etiology can vary from exogenous, a source outside the body, or an endogenous, that is, a source is in the body. So exogenous can be a prolonged use of glucocorticoid drugs or glucocorticoid therapy, whereas in case of endogenous, it can be divided into primary hypercortisolism or a secondary hypercortisolism. So, primary hypercortisolism is also called ACTH, independent Cushing syndrome. Its relative frequency is from 5 to 10%. It is more predominant in females as compared to males, so they have a ratio of 4 is to 1. Causes autonomous overproduction of cortisol by the adrenal gland, which will cause ACTH suppression. Therefore, because of adrenal adenomas, adrenal carcinomas, or a macronodular adrenal hyperplasia. Whereas the secondary hypercortisolism can be the source can be either from the pituitary or it can be either any ectopic source. So the pituitary ACTH production is called Cushing's disease, which has having a relative frequency of 75%. It is more predominant in female as compared to male, and the main causes is because of a pituitary adenoma or an ACTH secretion. The ectopic ACTH production, it can be from any source. There can be tumors in the lungs which produces an ectopic production. So the relative frequency is 15%. It is more predominant. It is equally in male and female. The main cause is a paraneoplastic syndrome, like ACTH secretion, causes like small cell lung cancer or a renal cell lung cancer. So, next, let's look into the clinical features of Cushing's syndrome. So, let's go according to the system. So, in skin, the skin might be thin, it can be easily bruisable skin where there can be stretch marks. Classically, there's purple abdominal stria or an ecchymosis, flushing of the face, hirsutism, acne. If secondary hypercortisolism is present, there is often hyperpigmentation, darkening of the skin due to an overproduction of melanin, especially in the areas that are not normally exposed to sun, for example, like palm crease or in the oral cavity, caused by excessive ACTH production because melanocyte stimulating hormone is cleaved from the same precursor as ACTH. Hyperpigmentation is not a feature of primary hypercortisolism. So, when you see a patient with hyperpigmentation, we have to think about secondary hypercortisolism, not the primary. Next, the neurophysiological. They can be lethargy, depression, sleep disturbances, and psychosis. In case of musculoskeletal, there can be osteopenia, osteoporosis, pathological fractures, avascular necrosis of the femoral head, muscular atrophy or weakness. In case of endocrine and metabolic, there can be insulin resistance, which causes hyperglycemia or diabetes mellitus, which causes mild polyuria in case of severe hyperglycemia. And there can be dyslipidemia, weight gain characterized by central obesity, moon phases, and buffalo hump. They can be in males there can be decreased libido, and in female there can also be decreased libido, virilization, and an irregular menstrual cycles. Secondary hypertension can be seen in 90% of the cases. There can be increased susceptibility to infections. Next, this is an interesting slide about a cushingoid. Cushingoid is an acronym for the side effects of corticosteroids. So what we can see like cataracts, ulcers, stria, that is thin lining or hypertension, hirsutism, hyperglycemia, infection, N for necrosis, G for glucose elevation or hyperglycemia, O for osteoporosis, I for immune suppression, and D for depression. These can be remembered by the acronym Cushingoid. So here's the picture with the manifestation of Cushing syndrome. Next, next, let's look into the diagnostics. The general laboratory findings, what we find is there will be an hypernatremia, hypokalemia, metabolic alkalosis, hyperglycemia, which is due to the stimulation of gluconeogenesis enzyme, for example, like glucose 6 phosphatase, and inhibition of glucose uptake in the peripheral tissue. Hyperlipidemia, hypercholesteremia, and an hypertriglyceridemia. Leukocytosis, predominantly neutrophilic, eosinopenia, and thrombocytosis. And here is a brief overview of the screening of patients who come with Cushing syndrome. So, when we suspect a patient with Cushing syndrome, first we ask patient for if they are using any glucocorticoids. So, if yes, then we can say it's an exogenous Cushing syndrome. If they say no, then we go for the screening test. We screen for 24-hour urine cortisol or a low dose dexamethasone suppression test or a midnight salivary or serum cortisol. If it is negative, then Cushing syndrome is not likely. If it is positive, further we evaluate for serum ACTH. Why are we evaluating for serum ACTH? Because we need to differentiate between primary or secondary. So the treatment varies depending upon that. So we have to check for serum ACTH. If the serum ACTH is low, it is likely to be ACTH independent Cushing syndrome or the primary hypercortisolism, which can be then we can go for a CT or MRI of the abdomen for screening for adrenal glands. And so we can see a tumor like adrenal adenoma, adrenal carcinoma, or an hyperplasia of the adrenal gland. Then we evaluate for surgery. If the serum ACTH is normal or it is elevated, then we can differentiate it as secondary hypercortisolism or ACTH dependent Cushing syndrome, cortisol or ectopic ACTH production. Now we have to find the ectopic source. So for confirmation, first we do a high dose dexamethasone suppression test or a CRH stimulation test. So if the dexamethasone suppression of ACTH increases in ACTH cortisol with CRH, then we do go for a cranial CT or MRI, which will suggest us for a pituitary adenoma that will lead to the Cushing's disease. Then we evaluate the patient for the surgery. If no dexamethasone suppression test of ACTH increases in ACTH or cortisol with CRH, then there is an ectopic ACTH production somewhere in the body. Then we suspect a small cell lung tumor or a renal cell carcinoma or a carcinoid. So depending upon which where the ectopic foci is present, then we search for the primary malignancy and then we further proceed to the treatment. So, next. So, identifying the cause of hypercortisolism. First, we go for the hormone analysis. Once glucocorticoid therapy has been ruled out, the following tests are used to identify the cause of hypercortisolism. Serum ACTH levels. If it is low, if it is less than 5 pg per ml, we have to suspect primary hypercortisolism, which can be an adrenal adenoma or a carcinoma. If it is normal or it is elevated greater than 20 pg per ml, then we can suspect a secondary hypercortisolism. If secondary hypercortisolism is suspected, one of the following tests may be used to differentiate between Cushing's disease and an ectopic ACTH production. High dose dexamethasone suppression test, adequate suppression of cortisol levels to less than 50% of the baseline will give us a diagnosis to Cushing's disease. If there is no suppression of ACTH, then it can be an ectopic ACTH production. So then we have to go for CRH stimulation test. ACTH and the cortisol level increases further than its Cushing's disease. No increase in ACTH or cortisol level, then it can be an ectopic ACTH production. Only Cushing's disease remains susceptible to suppression. High dose dexamethasone suppression test or stimulate CRH test or cortisol secretion. So, to identify the source of production of cortisol is really important for proceeding with the treatment. So, so let's see a brief overview of the tests. So, when an ACTH level is normal, there is no suspicion. So, when ACTH levels are decreased, then we can suspect for primary hypercortisolism. And if they are increased, ACTH levels are increased, then we can suspect for a Cushing's disease. And if ACTH levels are increased, we can also suspect for ectopic ACTH secretion. Next, we go for a dexamethasone suppression test. Low dose dexamethasone suppression test. In case of in a normal person, there's be decreased cortisol. In there, in case of primary hypercortisolism, it will be normal, and in Cushing's disease also it will be almost normal. In ectopic ACTH suppression is also it will be normal. In case of high dose dexamethasone suppression test will be reduced in a normal individual. In case of primary hypercortisolism, it will be normal. In case of Cushing's disease, it will be decreased cortisol production. In case of ectopic ACTH secretion, it will also be normal. So, next is the CRH test. It will be ACTH will be increased and cortisol increased in case of CRH test in a normal individual. If the person is having a primary hypercortisolism, then the ACTH and cortisol values will not change. In case of Cushing's disease, there will be increased ACTH production and increased cortisol production, so we can confirm that there might be a tumor in the pituitary gland. If the ACTH and the cortisol values doesn't change or it's normal, then we can suspect for an ectopic ACTH secretion. So next, depending upon this, then we go for an imaging. Imaging is usually used for the localization of the tumor. So if there's a primary hypercortisolism, then we go for a CT or an MRI of the abdomen to find the adrenal tumors. The adrenal cortex contralateral to the tumor shows atrophy due to the reduced ACTH stimulation. If Cushing's disease is suspected, CT or MRI of the skull can be done. If Cushing's disease, CT or MRI of the abdomen shows bilateral hyperplasia of both the zona fasciculata and zona reticularis. If no findings are present on neuroimaging, we can perform a bilateral sampling of the inferior petrosal sinus in order to measure ACTH levels. If ectopic ACTH production is suspected, then we go for a chest X-ray or a CT abdomen or a CT pelvis. Next, depending upon the diagnosis, the treatment also varies widely in Cushing's disease. In case of endogenous Cushing syndrome, if it is inoperable disease, then we go for drugs. We give drugs to suppress the cortisol synthesis. So it can be metarapone or mitotenin or ketoconazole. Operable disease, surgical therapy is the treatment of choice. Pituitary adenoma, transpenoidal resection of the pituitary adenoma can be done. ACTH secreting ectopic tumor, resection of the ectopic foci, for example, a bronchial carcinoid. In adrenocortical tumor, there can be a laparoscopic or an open adrenalectomy, the surgical procedure to remove one or both the adrenal glands. In Nelson syndrome or a post-adrenalectomy syndrome, can occur after bilateral adrenalectomy in patients with a previously undiscovered pituitary adenoma. The main pathophysiology of Nelson syndrome is in case of bilateral adrenalectomy, there is no endogenous cortisol production, no negative feedback from the cortisol on the hypothalamus. So there is increased CRH production, uncontrolled enlargement of the pre-existing ACTH secreting pituitary adenoma, increased secretion of ACTH and the melanocyte stimulating hormone will cause symptoms of pituitary adenoma and an increased melanocyte stimulating hormone. The clinical features of Nelson syndrome are headache, bilateral hemianopia, cutaneous hyperpigmentation. The diagnostics, it has high levels of beta melanocyte stimulating hormone and ACTH. Pituitary adenoma on MRI confirms the diagnosis. In case of exogenous Cushing syndrome, that is the glucocorticoids which have been supplemented in a person from outside. So we have to lower the dose of glucocorticoids. Consider we can use an alternative glucocorticoid like azithromycin. So, guys, that's it for this lecture. Thank you all for watching. Please do like, share, and subscribe to my channel. I'll make more medical related videos and have a wonderful day.